Thank you very much. So today we are going to talk about a very complex situation that we all have been through during our daily practice. So the staghorn stones, which are large branched stones that exhibit a coral-like or antler-shaped morphology occupying a large pyrocallistel system. The exact definition remains debated, and I think it's better to define them more by the anatomical extension, like in the picture A or B, so complete or partial staghorn, more than the size only. Those spectrums of stones represent a complex stones because they are often associated with infection and a decrease of the renal function. The staghorn calculi arise from urease producing bacteria like Proteus, Klebsiella, which will hydrolyze urea into ammonium and carbon dioxide. NH4 and bicarbonate generation will consume H+, and we will have a pH that will arise more than 7. Then the crystal will form in a pH-dependent environment, and we will have like the formation of the carbopatite in a pH more than 6.8 or struvite for more than 7.2. So in the center cornerstone of this physiopathology, we have the bacteria, and we have to take into consideration that staghorn calculi will not be treated only by surgery, but also by medical treatment. We have additional promoting factors like mucus inflammation matrix, which will aggregate the calculi, and also the ammonia will damage the urothelial mucosis and will produce a bacterial adhesion. There is also some favorable clinical situation that will have to be considered before treating the patient. So all those factors will be together to have a rapid and self-sustained stone growth. So the first step to answer the question, should I use the percutaneous technique, ureteroscopic or ECIRS, is to know how to correctly measure a staghorn calculi. The traditional classification are poorly reproducible because they were only based on the size of the calculi. Of course, if we use a CT scan, we will have an improvement of the assessment of the stone volume, but this is the first key message. Volume alone does not reflect the all true complexity of the calculi. This is why we have morphometric scores that will integrate, yes, the volume, but also the spatial distribution. So there is many morphometric scores that have been published and has external validation, and they are today very commonly used. We have, for example, the GI stone scores, the stone scores with an acronym of different parameters. We have the system published by the Andrological Society on the Korean score. So if they are very useful for the daily practice, they have very important limitations in the staghorn calculi. Why? Because they don't have a standardized definition, and also they have no parameters for the hardness, the volume, but also the variants of anatomy, and we will see that the anatomy is the cornerstone of the treating of those calculi. For example, the Korean system does not have a specific staghorn criteria. So, okay, those morphometric systems provide an objective and a quantitative assessments, but they are inadequate for staghorn calculi. In 2012, the Mishra team has published the first specific staghorn morphometric classification. And this is very interesting for two things. First, of course, because it's specific of the staghorn, but also because it's based on the total stone volume, but also the morphology of the callus. With the statistical analysis, we can predict the number of the tracts that will be necessary to treat the patient, but also to predict the number of stages that we use to treat the patient. The limit is, of course, this is time consuming, so we can't use it for a daily practice. A very important other key message is that residual fragment in the treatment of staghorn calculi is unacceptable. Why? Because there are three things. First of all, there is a high stone risk progression, and also infectious complication that are potentially life-threatening. We have also a renal deterioration. So when we want to choose which is the best between ECIRS, percutaneous or the combined treatment, we have to think that we have to choose the treatment that will achieve the maximal stone-free rate. For that, the guidelines are pretty clear. For the European Neurological Association, we have to use the percutaneous technique as the first line of treatment for all the calculi more than 2 centimeters. But for specifically the complete staghorn calculi, there is only a consensus and not a recommendation. If we go more deeply in the recommendation, we see that there is only one mention for the combined treatment, and they have same equivalence outcome. This is the same position for the American Neurological Association. More than 2 centimeters, we have to use as first line of treatment the percutaneous technique. The French Neurological Association has published the only recommendation on the combined treatment, so endoscopy combined intrarenal surgery, ECIRS, and we have to use this technique if we have a complex situation. So to have a conclusion for the guideline position, percutaneous treatment is the first line for the staghorn calculi. We will reserve the ureteroscopic option only when percutaneous is not feasible, and we have to do ECIRS when there is a complex situation. But we have to keep in mind that there is no specific dedicated recommendation for the treatment of the staghorn calculi. So when we don't have recommendation, what we do, we go to the literature. So for the percutaneous in staghorn calculi, there are many cases that have been reported, many series with different number of patients, different size of calculi, complication. So there is here 3 key messages. First of all, the percutaneous technique gives us the best stone-free rates, up to 90%, but at the cost of multiple tracts and also a very important risk of bleeding, and this is an important concern when we do the percutaneous technique. We can safely use the mini percutaneous technique, and this has been shown by this first systematic review published in 2025 with more than 1,000 patients. And the mini NLPC can be safely used, and we have the same results on less complication than conventional percutaneous, and that has been published by the American Neurological Association. There is no specific complication after a percutaneous for staghorn calculi, but there is a higher frequency and severity of those complications, up to 18%. Why? Because we have to use more aggressive maneuver. This is a complex access with multiple tracks and a prolonged operative times, and there is also a more important risk of urosepsis. About the ureteroscopy and treatment as monotherapy for the staghorn calculi, the evidence-based medicine is very limited, and there is very few heterogeneous publications. Stone fragment rates go from 30 to 90%. It's often multiple sessions, so yes, we have a lower risk for the patient, but we have also a limited efficacy. So for me, there is only 3 situations where we have to use the ureteroscopy technique in the treatment of staghorn calculi. First of all, as a part of ECIRS, and it's of course because it will enhance the vision, visualization, and stone clearance. And second point is very interesting, is a salvage strategy after percutaneous technique. Why? Because we have to treat all the residual fragments. We saw that the residual fragment will increase the morbidity for the patient. As monotherapy, it's only an alternative. In selected patient, it's feasible, but we have to inform the patient that it will be a multi-stage procedure in patients with severe comorbidity or that refuse the percutaneous technique. Just to mention that a few authors has published the option to use the extracorporeal shock wave after RIRS to improve the stone fragment rate. It's not recommended because even if in this largest publication, they require multiple sessions up to 26, and in practice is infeasible. ECIRS is a very interesting strategy to treat the staghorn calculi. We will use at the same time ureteroscopy and percutaneous technique. Why? Because we will have the advantage of both techniques. We will have a fully calyxial access, a reduced need for multiple tracks. Also for the puncture and dilatation, it will be more safe, and we will have a better vision. If we use it specifically for staghorn calculi, it will have many advantages. We will have a retrograde debulking that will ease us the placement for the guide wire and also for the tract dilatation. We will have a synergic work, and also we can use some technique like the pass the ball maneuver, which is simply a fragment reposition. Finally, the ureteroscopic inspection at the end will clear and treat all the residual fragments. So about ECIRS in Staghorn calculi, there is also a very important literature. We have a high stone-free rate. It's a single tract approach, so we lower the bleeding, which is the main concern in percutaneous technique, but we have to mention that there is more infectious complication. So if we compare the technique between them, there is those very interesting papers that have been recently published. Two meta-analyses on the one randomized controlled trial, and we see that ECIRS will improve the stone fragment rate and lower the complication and ancillary procedure. Just to mention that we also can safely use ECIRS in pediatric population, and that has been first studied in 2024. There is a very limited literature that compare front-to-front percutaneous technique and ureteroscopy, and of course it was expected the percutaneous technique will have a higher stone-free rate with a risk ratio of 1.6. Before choosing the best technique, we have to keep in mind that there is not only the size volume, there is also the architecture of the kidney, and we have to keep in mind some characteristics like the calyceal orientation, infundibular anatomy, but also the configuration of the renal pelvis. So if you have very important angle, maybe using ureteroscopy will be better. If you have a very complex with blind area situation, use the combined technique. There is also some situation that you have to take in mind before treating the patient. For example, if I have a horseshoe kidney, maybe it will be better to use the percutaneous technique. If I am treating a child, a mini NLPC, and if there is a very complex calyceal anatomy, ECIRS. So this is a proposed algorithm for treating the Staghorn calculi. First of all, we have to have the best evaluation of the complexity of the calculi. We can use only the scanner or more advanced staging system. For second step, we have to see if the patient is fit or not for surgery. If it's a patient with a simple anatomy, with no comorbidity, go to percutaneous, and there it's like for the guidelines. For more complex situation, go for combined strategy. And if the patient has high risk of anesthesia, we can do monotherapy of ureteroscopy, but we have to inform the patient that it will be probably a stage procedure. And the last step, we have to manage the residual fragments because they are linked statistically to more morbidity. There is some perspective, future, to treat better our Staghorn calculi. For percutaneous technique, we will have the miniaturization of the devices. We will have the suction system, a better laser, and of course, all that will be driven by the artificial intelligence and simulation. For ureteroscopic, the question is, will it be a standard of care in monotherapy for Staghorn calculi? Maybe, with a better endoscope improvement, aspiration, and laser. And I think that we have to more standardize the use of ECIRS. So to conclude, Staghorn stones are high-risk infectious disease that require two things: individualism, but also anatomy-driven strategy. We stick to the guidelines, percutaneous technique as first line, ECIRS in the complex Staghorn, and we have to use ureteroscopy as monotherapy only in selected high risk. It will be staged, or also for salvage after percutaneous. Thank you.